lumbar spine, which is the lower back, on a patient with two herniated discs, one at L4-5, the other at L5-S1. She has back pain and pain down into her right leg, intermittent symptoms in the right leg consistent with radiculopathy, which is problem with the nerve root. She also has piriformis and sacroiliitis, which are a completely different issue, affecting the muscles in the butt cheeks and the SI joint, the sacroiliac joint. So that will be addressed by Dr. Patel later on. Good afternoon. This is Dr. Duke Majan. Are you okay? She's awake. She's laying on her tummy. We're going to get started, okay? You're going to be fine. The first thing I'm going to do is give you some numbing medicine. So when I do that, you'll feel a little stick and burn. All right? But don't try to move or get off the table. It's going to be okay. I'll let you know how everything is going. You feel my hand back here? Okay. That's just my hand. I'm going to give you a little poke with a little stick and burn. That's just the numbing medicine going in, all right? That's the worst part. Just relax. Everything's going to be okay. It does burn, huh? Yeah. Well, that'll be over in just a minute if you're just patient with me. All right. Now listen, during the surgery I may ask you a question, okay, if you feel any pain. I need to know if the pain is in your back or if you feel it down your leg, okay? So just say back or say leg, depending on where you feel it. All right. We're going to go ahead and get started. So we're treating L5-S1 and L4-5. Just leave it. We're on the right side. Everybody agrees we're on the correct side for this patient? Shot? Oh, really? All right, now when I say shot, we're talking about an X-ray shot. Go to a lateral, please. So we're going to start by accessing the L5-S1 disc through a transforaminal approach. She has two herniated discs, one at L4-5, the other at L5-S1. They're not giant herniations, they're small, but they are substantial and they're causing her to have lower back pain. She's had lower back pain for, I'm not sure how long. How long have you had back pain for? So you can't drop the fluoro, right? That's good. Okay, shot. Let's get that end plate of L5 lined up with S1. How long have you had back pain for? Do we know?
Since she was 28.
Huh?
Since she was 28.
All right, so how many years? I don't know what to make of that, Jordan. So 12 years. No, 14 years. 14 years of back pain. That's worse. So remember what we talked about, folks. You need to get the X-ray lined up with the spine before you really do anything. If you don't, then you could end up putting the equipment for the surgery in the wrong place. You know, yeah, move north and probably drop my side south. So the first thing we have to do is line the X-ray up with the spine. That looks pretty good, I've got to say. And we're doing 4-5-5-1. Everybody's in agreement. Why don't we leave it there and see what we've got. Shot. Let's get an AP. It doesn't feel like the facet. Just a quick AP. Yeah, too medial. All right, back to a lateral view. Shot. Shot. Are you comfortable? Shot. Just take it easy. Everything's fine. Shot. What is it? Shot. What is she saying? Anything? You can't make it out. She okay? You're doing good. You're doing fine, Shot. 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 Where do you feel that? Try not to move, okay, sweetheart? Shot. If you move, it really makes it difficult for me. Shot. 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 Once again, L5-S1 is the most challenging level. Shot. Shot. Right on the facade, Shot. You're using a pulse mode? Okay. Shot. Shot. You're doing really good. Everything's okay. Shot. Where do you feel that? Give me an AP. What's she saying?
It's in your back or your leg? Your back.
Okay, yeah, everything's fine.
The butt too? Again, not your leg. Back and body.
All right. Perfect. Let's go back to a lateral, please. You're doing great. Everything's fine. Huh?
Feel your feet now?
Look at her SI joints on that view. It's pretty impressive. She has some swelling in the joints, like an effusion. You can actually see it, which we're treating next. You're fine, Sean. We're close to that first bad disc, okay? You feel it in your lower back? But not down your leg, right? Huh? Butt cheek, but not your leg. Correct. Okay, good. You're fine. Do we numb this area up? I may need to numb a little bit more lateral. I'm not sure. Yeah. Do you feel anything? Huh? You don't feel it? It's good knife. Oh. Wow, look at that. It's impressive. We're doing L4-5 and L5-S1, right, everybody? Everyone's in agreement? What'd she say? All right, shot. I don't want to have a full conversation right now with her. I just want to know if there's an issue. If you're having a problem, just let us know. Otherwise, just try to relax a little bit. It's going to make it easier for us, okay? Everything's going really good from our standpoint. Sean? We're almost done. We're going to put you to sleep in just a few minutes. I just need I need you awake for just a little bit longer. Sean? Huh? Sean? Oh, you're doing great. Yeah. You're not doing anything wrong. Don't worry. Shot. All right, let's get an AP. It's perfect. Slipping in just under the facet joint. Doesn't get any better than that. Are you comfortable? Shot. Could her herniation be that big? You feel anything? Shot. Where? In your back? Okay. Just relax, shot. You're doing really good. Shot. It's like forcing. Shot. Where do you feel it, shot? Your butt cheek and your back? Shot. Do you normally get back pain? Yeah. I couldn't understand what she said. You do normally get back pain, right?
Yeah, I said if I woke up without it, I'd probably think I was dead.
Okay. Is that your typical back pain? Is that where you typically get it?
Yeah.
How bad is that on a scale of 1 to 10? 10? So L4-5 is a 10. Concordant. Okay, so we're just testing her two discs that we've accessed, the L4-5-5-1. Remember, we don't know for sure where her back pain's coming from. I'm using an educated guess, so to speak, but I'm looking at on her exam where the pain is, and it localizes to L4-5, L5-S1. I'm looking at her MRI, and on her MRI there are two bad discs, one at 4-5, one at 5-1. The other discs look fine. So I'm using the topographic localization of her pain on exam because the truth is discogenic pain is transmitted to the brain somatotopically through a somatotopic pain pathway through what are called sensory afferents, all right, somatosensory afferents, and that's why it can be so highly localized for the patient where the pain is. And then of course the MRI, and now we just confirmed the pain at L4-5 with a discogram. We just tested the disc and it's causing her typical back pain, 10 out of 10. Yeah, it's still going to hurt probably for a little while. How bad is that on a scale of 1 to 10? All right, I apologize. We can put you to sleep now. Look at the large tear, folks, on the back of 5-1. Huge amount of dye coming out through the tear. That's where her back pain's coming from, is that annular tear. And that's what we're going to fix. When you wake up, we'll be done. And that pain will be gone for the rest of your life as long as you don't re-injure your disc doing anything stupid. All right. Just count from 1 to 100 for me, and when you wake up, we'll be done. Count out loud. Keep going. Nice job, Jordan, today. Shot. Keep going. Don't stop. Let me know. Let me know that you can count to 100. I want you to count in Latin for me, please. I'm just kidding about the Latin. What'd she say? All right, when you wake up, we'll be all done and your back pain will be gone. Okay. Just keep counting. Let me know when she's asleep. So if you look at her x-ray, folks, this lateral view, Sean, I don't know if you can bring the x-ray up, but the pedicle of L5 is not as bad as the last case we did. Remember how short that guy's pedicle was? This patient actually has a longer pedicle at L5, so she doesn't really have the congenital stenosis we saw with the last case. She just has 2 damaged discs, and those discs are causing her back pain and intermittent pain down her right leg. You're doing great. Let's drop the table just about 1/2 inch, please. No, down. Good. Let's take a look at that. All right. Maybe bring it up 1/4 inch. Good. That should be perfect. Yeah, that's good. I like it. So let me know when you're ready, and we'll get started. I want her to be nice and comfortable. You're doing great, Shot. So that's the dorsal fascia right there that I'm hitting. I'm past it. All right, just take it easy. Everything's okay. Any questions from our audience?
None so far.
The dorsal fascia is the covering over the muscles in the spine, in the back. You're doing good. Everything's okay, Shot. Yeah, our guide wire hasn't moved. Our dilator's coming down. I'm just going to give our anesthesiologist a few more minutes to get our patient like sleepier, so where she's asleep, but her airway is still secure. So we don't want to do it too fast. All right, so what is the purpose of this surgery? The purpose of the surgery is to eliminate this patient's back pain and leg symptoms of leg pain, numbness in the leg, sciatica. So we're really treating back and leg symptoms, mostly pain, by repairing 2 herniated discs in her back without removing any bone from the spine. So most spine surgery, almost all spine surgery is done with removing bone, but we're able to do it without removing bone because we're coming from the side. Shot? Yeah, it's nice. So we're inside the foramen, right at the back of the herniation. And this is going to be more a stimulating area for the patient because this is exactly where her pain is coming from, is this herniation right here. Shot? So I'm actually touching with the tip of that metal device, I'm touching the part of the herniation that hurts, which is why it's so uncomfortable for her, because we're on the part of the herniation where all the pain comes from. I need to get this further, Shot. That's it right there. I need to go in just a little bit more. That's good. Because I don't want it coming out while I'm putting the tube in. Now, the whole surgery, can you guys see this, Sean?
Yes, we can.
The whole surgery is done through this little tube right here. You see that? 7 millimeter outer diameter tube. There's no other spine surgery as minimally invasive as what we're doing with the Duke laser disc repair. There's only a few surgeons in the world that know how to use this kind of equipment. It is not part of their normal training. I had to learn how to do it years after I was done with training, and I learned overseas by the Koreans, a German surgeon, a British surgeon, and a Chinese surgeon practicing in America. Probably the most influential was Dr. Young, over in Phoenix, Arizona. He taught me a lot. But then I adapted his technique. Some of the things that he's done for years I do, like the inside out. I start inside the disc and I work my way out. So once again, the whole surgery will be done through this tiny metal tube. This creates a passage from the outside world where we are in the operating room into the disc, right through the herniation. So there's no damage at all done to her spine. We're not hurting her spine in any way whatsoever. All other spine surgeries are going to hurt the spine because those surgeons are going to be removing bone and ligaments from the spine in order to do their surgery. Laminectomy, surgeon removes bone and ligaments. Microdiscectomy, surgeon removes bone, joints, and ligaments. Shot. Fusion, surgeon removes bone, joint, ligaments, and the disc. Shot. Artificial disc, surgeon removes the disc and ligaments. Okay, so this is the least invasive of all spine surgery. Shot. Let me see where we are. I need to pull this back a little bit just to see. Shot. All right, looks like we're inside the disc, which is good. Shot. I want to verify that. There it is. We're inside the disc. Shot. All right, perfect. So this technique of me starting with the end of the tube inside the disc and pulling back as I'm fixing the disc, that technique of inside out was taught to me by Dr. Young. And that's what he's famous for doing, is the inside out technique. Now, the annular repair that I'm about to do, the debridement, that's something I developed on my own. All right. Most spine surgeons talk about treating the herniation. Very few, actually none but us at Duke Spine, treat the annular tear. The annular tear is the source of pain. All these surgeons have been so close for all these years to the actual source of pain, but never knew that it was the annular tear. I discovered that by doing these surgeries, by cleaning up the annular tear and finding out the pain is gone as a result. And I published that information in 2012 for the first time. How are we doing, folks? Good? All right, so now we're going to go into the disc. So I'm advancing the endoscope, and there's the end of the tubular retractor, and there I've shoved some of the herniation down into the middle of the disc, and we're going to remove it with a grabber, and we're going to use a laser and a grabber to remove these pieces of herniation. How did these pieces of herniation get inside the disc? Well, because I just pushed it in there when I advanced the dilator into the disc through the tear. That tear is where the herniation is. So in essence, I pushed the herniation back into the disc, and now I'm going to remove the pieces. That's one of the advantages of Dr. Young's technique, the inside-out technique, is that you actually reduce the herniation. That's not something he described. There's the tear. That's what I'm after right now. That may be a part of herniation too right there. All right. That's a piece of herniation. I just detached some of it. This is all scarred up herniation right here. The cable, is there any way to give me a little bit more of the fiber, the laser fiber? All that mass there at 12 o'clock you're seeing is the painful part of the herniation. And I'm zapping pieces of it away with the laser, but I'm also going to have to remove some of it with the grabbers. Okay? So I've been doing this surgery now for 15 years. And in 15 years, I've done about 1,200. The only bad thing about this surgery, if anything, is that about 1% of the patients get a recurrent herniation. That means that we'll take care of their herniation and then they're going to go out and do something, and sometimes they don't even know what they did because they'll tell me I didn't do anything, and they come back and they have another herniation in the same place. Most of the time it's bigger, and they're symptomatic from it, so it needs to be treated. So 1% of the patients that I do the surgery on end up needing a second surgery at the same disc. That's not bad. A 1% reherniation rate that needs treatment is really good in spine surgery. As a matter of fact, it's the best reherniation reoperation rate of any type of spine surgery there is. With microdiscectomy, it's usually around 10 to 20%. Depends on which paper you read. That's a piece of herniation right there. So with the Duke laser disc repair, 1% is not too bad. You never know who's going to reherniate, but what I found is that people who follow my instructions and do the physical therapy don't tend to reherniate. It's the ones who don't do the therapy or don't follow my instructions, they're the ones who reherniate. The post-operative instructions are quite simple. Number one, you can't lift anything over 25 pounds for the first 6 weeks. Then you go up to 40 pounds. And I tell people, don't do anything over 40 pounds for the first year. Let that disc completely heal. You keep grabbing in the same place where you already have disc. Move your fingers and grab somewhere else. We've talked about that before, right? All right, here you go. The other thing you can't do is bend at the waist. You don't want to bend over and pick something up from the ground. If you do that, you're going to feel a little pop in your back, and that means you've just reherniated your disc. So no bending for 6 weeks. And then after 6 weeks, you have to just be really careful with your bending. Just bend at the knees. All right, there's the tear right there. You all see that? It's pretty ugly. That right there is the tear. A little bit of fat coming out. And then finally, the therapy is very important. Unfortunately, some of my patients don't get the message. I tell them to do the therapy. By the way, that's the end plate over there to the right. So we're really just right on the end plate. We're not going to mess with the bone at all. The end plate is the bone. But the physical therapy has to be done properly after this kind of surgery. Okay? And what that means is you have to do the right exercises. You have to do the right number of sets, the right number of reps per set. You have to do the right weight. You have to do the right technique. And all of that requires supervision. You understand? Supervision. People think physical therapy is just go out and do some exercise, but it's not. It's actually supervised therapy. And the supervision part means that you do the right technique, you do the right weight, you do the right reps, you do the right sets. What does that mean? Well, You want to do the right number of repetitions, okay? Repetitions are important in rehabilitation of muscles and joints. You need to do the right number, like usually it's 10 reps, let's just say, okay? You need to do the right number of sets, okay? So you have to do, what, 5 of them, 6 of them? I don't know. I don't have the answer, but Dr. Schrump is the head of our therapy. She knows the right number of reps, the right number of sets, the right form, and the right type of exercises to do. She also knows what you should not be doing. So she'll tell you, don't do these. Don't do hack squats, for example. You never want to do hack squats, deadlifts, any of that kind of stuff after having your back fixed. It's only going to re-injure your back. So I tell my patients, don't do deadlifts, hack squats, any of that kind of stuff. Even military presses in the gym can be very damaging to your lower back if you do it too soon. I had one patient who had back surgery a few years ago, and he was told in writing, don't do, what is it called? Don't do a specific exercise. And of course he went out and did the exercise and re-injured his back. So I'm mentioning this because it really happens. People don't follow the instructions of the doctor, and we're not giving really that difficult of instructions. We're giving pretty simple instructions. You know? But you do need to listen to those instructions and follow those instructions. Right, Luis? Almost done here. We have a little bit of epidural bleeding. I'm not concerned about it, but it is making your visibility more difficult. So it makes it harder for you to see what I'm doing. I still know what I'm doing. I don't need perfectly crystal clear view to do what I need to do. But unfortunately for you, you're going to have a hard time seeing what I'm doing. What's wrong, guys? Everything okay? I've got 5 minutes here, and then 10 minutes on the next one, and we'll be done. We let Dr. Patel know we need him in 15 minutes. Please, let's do that now, so that he's aware. Do you know Dr. Santiago down south by any chance? Which hospital do you normally work at, or is it more outpatient?
It's a surgery center called, it's a Dayland. You know where's Dayland?
No,
Dayland Mall?
I don't know that area that well.
Center, Miami.
I know Homestead. South Miami?
South Miami.
Oh.
It's a big surgery center.
Oh, okay.
Surgical Park, it's called.
You guys do any spines there? No? What do they do?
They do everything, orthopedics, like a hand surgery,
Ophthalmology?
food. They do UA, urology.
You know Dr. Gupta? Shailesh Gupta, ophthalmology? Manish Gupta, orthopedics? No? I take it they don't work there.
Orthopedics over there is Dr. Balaguer, the one that do hands.
Oh, okay. What do the GYN doctors do?
What they do, stereoscopy, DNC, laparoscopy.
So they're pretty busy there?
Oh yeah.
Gosh, we have a bunch of GYN doctors here that they don't
They've been
ever...
there for a long, long time.
Huh. I may want to have these guys that I know come do some cases. She doing okay? All right. Now the laser can actually stop bleeding. But that's not its primary purpose. And the amount of bleeding we're having is so minimal. But I'm almost done repairing this tear. And unlike the earlier surgery, I can still see pretty darn well. So I don't need to bring in the grabber as my technique to be able to see. This is just so scarred up right here. It's called, we call it collagenized. It means collagen. Collagen is basically scar tissue material, very white, very avascular. That's the white color. There's no blood vessels, no blood supply. And very thick, very tenacious. It doesn't zap away quickly with the laser like a herniated nucleus pulposus material. You know, the new stuff. A new herniation just zaps away within microseconds with the laser. This stuff, you have to work on it for a while. Problem is if I pull on the scope to get medial, you'll break the scope. Right, Luis? We've done that before. It's where you pop the lens on the scope. And then we have to spend thousands of dollars to fix it. So good news is I'm be done in 2 minutes here. Our first patient left. Our second patient wants to leave. He's ready to go. We may end up doing a quick video. Sean, if you want to call over to the recovery area and see how he's doing, maybe we can do a quick video. Huh? Yeah, Sean will do that. I need Sean because if he wants to do a quick video of him leaving, as soon as I'm done here, I'll be done in 10 minutes. We can go over and do that. Gosh, the scar tissue from, this is the annular tear, by the way, folks. I'm literally zapping away at it, just taking forever because it just so little of it comes out with each blast of the laser because it's so thick and it's been here for so long. And I need to get rid of enough of it that it'll promote it to heal properly. I'm just about done with it. So that looks pretty good. That looks good. The back here looks pretty good. I'll just zap a little bit over here and we'll be done with this level. Once again, this is L5-S1. And what you're seeing over there at 3 o'clock, that little blood coming out, that's the end plate of, let's see. That's going to be the end plate of the sacrum over there. And the L5 end plate will be just up here. And I think we're done here. What you got? He's ready to go? All right. Done here, laser off. That's just one of the two discs we're fixing. You let Dr. Patel know we're going to need him soon? Scope off. Any questions from our audience? That looks good.
We have had no questions.
Boy, sounds good. All right, let's get the next one done. Careful. Let me know when you're ready for the x-ray. Yep. Let's bring, by the way, you can actually see the screws and rods from her thoracic fusion, which I didn't do, by the way. I don't think I did it. I didn't do her thoracic fusion. Someone else did. You can't lower the floor, right? All right. A little more. Good. Shot. All right. So we're now going to do the L4-5 shot. Perfect. I'm going to take the needle out. But I didn't do her thoracic fusion, but she's had a fusion. She's had the screws and rods. And guess what? She doesn't want another one. She's a smart lady. She said, you know what? I've already been through a fusion. It was too painful, too long of a recovery. I'd rather have the Duke laser disc repair. Now, we could have done a fusion at L4-5 and L5-S1. That would have fixed her back pain. I could be fixing her right now with an open fusion. But the recovery for her would be much longer with an open fusion. And she would be in a lot more pain from an open fusion shot. And honestly, it's totally unnecessary, given the fact that she could have this laser surgery done instead. Minimally invasive. And by the way, no narcotic shot. That is. So patients who have the Duke laser disc repair, they don't need powerful narcotic medication after surgery for their postoperative pain, because we're not doing any kind of major bone work or muscle dissection in order to get the spine opened up so I could do her surgery. Does that make sense, Sean? So the Duke laser disc repair procedure you're watching now is so gentle that these patients only need usually Tylenol for their recovery. Shot? They don't take narcotics. We don't give them narcotics. We don't give them Percocets or Norcos or Lortabs. They all get Tylenol. She'll get obviously a little bit of medicine here, but she won't be taking powerful narcotics after surgery while at home, because we're not doing a fusion, we're not doing open back surgery. Shot? That's it right there. Shot? Shot? All right, we're in. And we'll get this fluoro out, and we'll get the last disc done. That's L4-5. Any questions? So the surgery you're watching will replace spinal fusions. And I can tell you right now, there are 6,000 spine surgeons in the United States. If all 6,000 knew how to do this surgery, they would stop doing spinal fusions, and they would do this surgery instead. The problem is they don't know how to do this surgery. And the second problem is they don't have this equipment, because it costs millions of dollars to buy this equipment. So they would have to buy it all themselves or get their hospitals to buy it, because you can't do the surgery without the right equipment. Yeah. Let's do laser. Both of these discs have extensive damage internally. And surgeons and doctors that treat back pain have known about a condition called internal disc disruption for many years. And this patient has internal disc disruption where the inside of the disc is massively damaged. You can actually see it on the MRI. On the MRI, the discs are very dark. And once again, her herniations they're not huge herniations. They're small. But we've already talked about this. The size of the herniation is not what's important. It's the effect that it has on the human body. And you don't need a big herniation to really cause a lot of pain and suffering in a patient. So damaged. Look at this. It looks so bad. Really incredible. Sorry, Sean, did you say there was a question or no?
No, there are no current questions.
In medicine, we have a term called necrosis. And to me, that's what that looks like. I've not seen a lot of... That's from a pretty significant injury right there to the disc. I mean, to me, it looks like there was bleeding internally into the disc, like from trauma. I don't remember her history enough. Does she have a history of trauma? Oh, she did. She fell off a horse and fractured her spine and probably injured these two discs. So she did have a substantial trauma falling off a horse. Wow. Well, and these two discs have basically been left untreated, probably for the reasons I told you. When a doctor looks at them, they can see them and say, you know what, they're definitely abnormal, but they're not bad enough for us to treat. Well, they should have been treated. Look at all this brown stuff. I've never seen so much. This is all probably hemosiderin. That's typically what would stain this color, hemosiderin, from a hemorrhage. Wow. I don't see a lot of hemorrhaging into a disc. It's pretty unusual, but it takes a tremendous amount of force and trauma to do that. Yeah. Yeah, I'm almost done. We only need a few more minutes, but if you want to change it, go ahead. So here's part of that tear right there. It's partially healed. You can see scar tissue on top there, like a little cap of scar tissue, but it's never healed properly, and that's why she continues to have pain from this disc herniation. So by using the laser, I can get rid of this damaged tissue that's causing pain, and the body will heal and replace it with good tissue that doesn't cause pain. Really what we're doing is we're helping her heal her own discs by getting rid of the tissue that is keeping the disc from healing properly using the laser. This part right here is called the annular debridement. We're nowhere near the herniation. We're inside the disc. So this is the essence of the Duke laser disc repair procedure, is the annular debridement. There is an internal herniation. It's called the interposed nuclear herniation, but nobody ever talks about it because most doctors don't know what it is. But everyone thinks a herniation is what sticks outside the back of the disc. But for example, if your intestine is herniating through your inguinal canal, you don't wait for the intestine to stick out of your skin to call it a herniation. It's a herniation even when you don't see a mass or there's no palpable mass. there's still a herniation because the intestine is in an area it's not supposed to be. When the nucleus pulposus is inside the annular tear, it's still herniated, but it's called a contained herniation. And these contained herniations are very painful and very symptomatic. And the reason we teach you this is because too many doctors ignore patients' complaints when they have a contained disc herniation. Another name for it is a disc bulge. Disc bulges and contained disc herniations are the same, and doctors ignore them, and they ignore patients' complaints. And they shouldn't do that, because those can be very painful and symptomatic and need treatment, just like this patient is getting. And it's wrong to deny patients care when they have a small herniation. It's wrong for the doctor to say, there's nothing wrong, you don't need treatment. That's absolutely wrong. We're almost done. Less than 5 minutes, doctor? About 3 minutes. No. Yeah, I'll just come over there and do the final questions. All right, folks, if you've got any questions, this is the time to type them up, and we'll answer them for you. I'm going to give you just a few more minutes. We're pretty much done with the Duke laser disc repair here. I'm going to be done in 30 seconds. And I'm going to come and answer any outstanding questions you may have about the spine or spine surgery or treatments, diagnostic tests, anything related to spine. And then this patient's going to go to recovery, and we'll probably get her home in about an hour. But this is the end of the disc herniation right here. This is the last bit. So this is the last part of the tear. Once again, you can see the body's tried to heal it. It's just been unsuccessful at doing that. And as a result, she's had ongoing pain in her back. So what are you going to be selling with Stryker, Kim? Huh? What kind of implants? Have you done that before? Huh? How do you know you're going to like that? That's fair. Yeah, so she's starting to feel it a little bit. This is the bad part of your disc where all the pain's coming from, so it's not surprising that she's starting to feel it more. She's got nice anatomy, so maybe what I'll do is I'll show you the nerve root. I'll show you where the nerve root is, okay? You're going to get to see it. I'll show it to you in 10 seconds, as soon as I'm done with the laser. All right. Laser off. So the nerve root's going to be right here. And it's actually in that soft tissue there. So you're not going to be able to see the dura. Okay. Done. Off scope. Thanks. Folks, I'll show you the incision that we did everything through. You're all done. We're done. You did great. I know, it's a little uncomfortable. I'm sorry. I'm just applying some pressure to keep the bleeding, keep it from bleeding. I don't think it's going to bleed, but just in case it does. You did great. All right, Sean, you ready to see this incision? Let's get a light on.
Yes, we can see it.
All right, so the whole incision, everything was done through this little cut right here. Little pressure here, gentle. All right, good job, everyone. Thank you. Dr. Patel should be here, right? To do the... All right. Good work, everyone. I'm going to call the EBL 3 mil. I'll come and answer any questions, Sean, and then we'll head over to the... Folks, we're going to hopefully do a nice interview on one of our patients today before they go home. This was what side again? Right. And then we have a bilateral piriformis. Great job, everyone. Really good. Dr. Digmajan here with Sean, and we just finished up our third case for the day. Duke Spine Institute is the only center in the world that streams live spine surgery every day that we do surgery. You may see a live stream once in a while from another facility, maybe once in a year or so. Mostly you'll see edited surgery where they do the surgery, film it, and then they edit it and then post it. But Duke Spine Institute has been streaming live spine surgery for 6 years, ever since we opened our doors and did our first surgery. Every single surgery is streamed live. It's streamed live over YouTube, Facebook, and Twitter, and Periscope. We stream our surgeries live so that the public can watch and learn and ask questions during the surgery and get answers during the surgery so that you can see the anatomy of the body, of the spine, so you could understand what it is we're trying to do surgically, how we do it. And you can see what a pedicle screw looks like, what rods look like, what a cage looks like, what a laminectomy looks like, what a microdiscectomy looks like. We've done them all. We've streamed them all. Today we did 3 surgeries called Duke Laser Disc Repair. It's the most advanced spine surgery in the world for treating herniated disc or spinal stenosis, radiculopathy, any of those conditions. Our patient, the first one from Texas, basically avoided a massive open back surgery with osteotomies and derotation of the spine with screws and rods, cages. She avoided all that, which would have been, a very risky surgery. She had the laser surgery done instead. This patient, we just did surgery. She injured her back 14 years ago falling off a horse, and she had 2 badly damaged discs, and we just repaired both of them within 30 minutes. And she's going to get out of here 30 minutes after surgery and go home and be home recovering tonight at her own home and with her family, and taking Tylenol for post-operative pain. You can't do better than that, folks. It's the very best spine surgery in the world. You're not going to have this type of surgery where you live, so you're going to have to travel to Florida. That's okay, because we're located near Orlando, and you fly into Orlando, you visit Mickey Mouse, and you come see Dr. Duke Majan for your back surgery. Orlando's a wonderful place to be with your family or just by yourself to get your back fixed. And yep, we've been doing this surgery 15 years, 0 complications to date in over 1,200 procedures. Pretty remarkable. All right, we're going to do a live stream in about 5 minutes on our post-op. So check back in 5 minutes.